Welcome to our symposium entitled Preventive Medicine in Older Age, Comorbidities, Deprescribing and Dementia. Thank you for joining us today. I'm Dr. Lucy Stirland from the University of Edinburgh, UK, and I'm pleased to be chairing this session of talks from 3 European early career researchers. We know that the concurrent prescription of multiple drugs, or polypharmacy, is very common among older people, and that it's associated with dementia and cognitive impairment in various ways. This symposium today includes 3 diverse talks on this topic. The 3 speakers will explore large-scale epidemiology of these associations, personalised preventive strategies for dementia, and then specifically the use of statins and aspirin in people with dementia. The first speaker is me, Dr. Lucy Stirland. I'm an academic geriatric psychiatrist at the University of Edinburgh, UK, and I gained my PhD in 2020. My current epidemiological research uses data from routine healthcare and cohort studies to examine the relationships between multimorbidity and polypharmacy with mental health and dementia. I work in a postdoctoral clinical lectureship funded by the Scottish Government's Chief Scientist Office and NHS Education for Scotland. My talk is entitled Polypharmacy and Dementia, Population-Based Longitudinal Record Linkage Study of 1.23 million people. And my opening slide is a picture of the skyline in Edinburgh, which is where I'm speaking to you from today. So what's polypharmacy? As I'm sure all of you know, it's very common in older people to be taking multiple medications at once, and this is usually referred to as polypharmacy. Some Swedish research by Lucas Morin and colleagues in 2018 found that about 44% of adults aged 65 years and over regularly take 5 or more drugs every day. And the same research study found that looking at the number of drugs taken per diagnosed condition, in people aged 75 years and over, the majority of people took at least 1 drug per condition, and the mean number of drugs per condition was 1.9. So what counts as polypharmacy? How many drugs counts as a lot of drugs? Well, this varies between different studies, and the most commonly used cutoff is 5, with a study in 2017 finding that 5 or more concurrent drugs is most often the single cutoff used to define polypharmacy. And how is polypharmacy linked to dementia? Well, there are various different ways in which it's linked to dementia. These can be causative epidemiological associations and also real-life patients with dementia experiencing polypharmacy as a coincidence of their diagnosis. So causally, to start with, there are specific drug classes which have been linked with dementia, including benzodiazepines, anticholinergics and anticonvulsants, and whether these have causative effects or are markers of other disease processes is unclear, but within polypharmacy, if people are taking multiple medications, including these drug classes, that can contribute to cognitive impairment or dementia. And we also know that people who have dementia themselves are more likely to take multiple medications than people without dementia. A systematic review by Delgado and colleagues published in 2020 found that among 31% of people with dementia living in the community, there was potentially inappropriate prescribing. So some of the medication they were prescribed was not appropriate for their stage of dementia, or preventive medications which were no longer suitable. That figure rose to 42% in people with dementia living in residential care. Then looking at the epidemiological association, this systematic review, a meta-analysis published in 2019, looked at different cutoffs for dementia and how those affected that relationship between the two at an epidemiological level. So looking at 6 studies, their meta-analysed risk ratio for dementia using the cutoff of 5 or more drugs to mean polypharmacy, was the risk ratio was 1.30 for dementia. And I'm assuming that that's compared to people on no drugs, although it's not entirely clear from the paper. And comparatively, the risk ratio for dementia among people taking 10 or more drugs was 1.52. So there's an established epidemiological link between polypharmacy and dementia, but the studies so far tend to use cut-offs, which loses some of the granularity available when using continuous data measures. So I'm going to present to you today some analyses using data from Scotland. So for those of you unfamiliar, Scotland is the nation in the top half of Great Britain, and the map here on the right shows population density. So our overall population is about 5.5 million, and 80% of those people live in urban areas, with half of the population living within 10 miles or 16 kilometres of the motorway that runs between Glasgow and Edinburgh in the central area here where the darker spots are. Everyone in Scotland is entitled to free healthcare at the point of delivery that's funded by taxpayers through the National Health Service. And National Health Service, NHS Scotland, has funded prescriptions for all residents of Scotland since April 2011. So they're free at the point of delivery. And before April 2011, there was a flat rate of £5 for a prescription, with some exemptions for certain chronic conditions and older adults. Because this is universal healthcare coverage, that means that the routinely collected NHS data covers the entire population. And this is now organised by a body called Public Health Scotland. They take the routinely collected data and store it, use it, and securely allow researchers to access it using appropriate measures. The data are linked because each individual has a completely unique an identifying number called the Community Health Index, which is apparent on all of their healthcare contacts and other things such as their death certificate, allowing linkage of various different health records. So the study that I'm going to describe today uses data from three aspects of the Public Health Scotland dataset. So firstly, there's community prescribing data. So every prescription that was dispensed in Scotland during the time period we're talking about is recorded and goes into the Public Health Scotland database. So this is every person in Scotland who received one or more medicine in a certain time period, the number of medications they took plus the list of every medication that they had in those 3 months is in the prescribing dataset. Through the CHI, the CHI, that linking number, that every prescription in the prescribing dataset contains that number for each individual. So that dataset is linked to the CHI database, and the CHI database also includes demographics such as age, gender, and the postcode, which allows the deprivation index to be calculated. Using that same CHI number, the dataset can also link data from death certificates. So that includes the time period from when somebody entered the dataset to when they died, and also the cause of death that was recorded on their death certificate. So the dataset that we're looking at includes everyone in Scotland who was aged 50 years or over on the 1st of January 2009, who received at least one prescription in the first quarter of 2009 so that they appear in the prescribing dataset. And the prescribing data is from the first 3 months of 2009, but with a follow-up period of 8.5 years to June 2017. So the longitudinal period is 8.5 years, during which time death of any cause or with dementia was measured. The data are accessed through something called the Public Benefit and Privacy Panel, which ensures that all requests to access these data are ethical and in the public benefit. This is because the data are routinely collected and have not been consented specifically for research use. So they're very strictly anonymised, very securely controlled, and safely accessed through this remote safe haven desktop. The linkage all takes place by data analysts within Public Health Scotland, and researchers only have access to the anonymised data set that doesn't have any identifiable features. So the statistical methods we used for this study were simply Cox proportional hazards models with an exposure variable of continuous drug count, so that's from 1 upwards to the total number of possible drugs that somebody could be on. We didn't use a cutoff of 5 or more, meaning polypharmacy. We purely looked at the increasing number of drugs. The outcome variables that of particular interest was mortality, where any subtype of dementia was recorded on the death certificate, but I've also included the results from all-cause mortality as an interesting comparison. And in the Cox models, the covariates were age, gender, deprivation index, and care home status, whether the person was resident in a care home. So moving on to the results, the sample size was 1,225,894 people. So remember, these people are all aged 50 years and over. 56.1% of them were female, and the mean age was 67.4 years with a standard deviation of 10.8 years. Remember, these people all took at least one drug. So among these people who took at least one drug, the mean number of drugs taken was nearly 5, with a standard deviation of 3.65. In the 8.5-year period of follow-up, 336,244 people died, so that's about a quarter of the cohort. And of those deaths, there were 58,358 where dementia was mentioned on the death certificate. So that's about 17% of the people who died in that period. Just to note that because we only had data on people who took at least one medicine, that excluded 660,000 people who were taking no drugs at the point of entry. And just for interest, I've added a heat map of the drug count against age in the beginning of 2009. So you can see that the age in 2009 is on the x-axis, and the number of unique drugs, the maximum was 38, received in a 3-month period, on the y-axis. You can see here that the darker areas are those with increasing frequency, and unsurprisingly, the majority of people at the younger ages within this cohort were on a lower number of medicines. I think you can also see here that there's a trend towards an increase as people age, and interestingly, around 61, 62 years here, you can see a peak, which is to do with the population peak. That's the people who were born after the Second World War, or baby boomers as they were known. So that's just to do with an increasing number of people at that age group rather than specifically to do with their medication use. Another interesting descriptive statistic is the number of drugs people were taking according to their deprivation. So deprivation was measured in this cohort using the Scottish Index of Multiple Deprivation, calculated based on their postcode, and it looks at various different aspects to calculate deprivation. You can see here that the most deprived people, that's group 1, so on the far left, the mean number of drugs taken was about 6, compared to the least deprived people in the 10th decile, that's the far right, the mean number of drugs taken was about 4.5. So there's a big difference there between the least deprived people on the right and the most deprived people on the left in the mean number of medications. So then moving on to the results of the Cox proportional hazards model. With each additional drug, so using not one drug as the reference, with each additional drug, the hazard ratio for mortality with dementia recorded anywhere on the death certificate across all age groups was 1.027, so looking like a 2.7% increased risk of dying with dementia for every additional drug a person took. Stratifying that by age group, the hazard ratio for people aged 50 to 64 years old was 1.075, so 7.5% increased risk, and decreased slightly for the 65 to 79-year-olds to 1.043, and then again in the over 80-year-olds, 1.009. And all these analyses were adjusted for age, gender, deprivation, and care home status. These graphs show those hazard ratios. So the hazard ratios we've just seen about mortality with dementia are on the right-hand side on this graph, and I've included the all-cause mortality comparatively just to show the difference. So you can see that the hazard ratios for all-cause mortality are higher than those for mortality with dementia on the death certificate, but in both analyses, the association was stronger in people aged 50 to 64 years and declined as people got older, perhaps suggesting that the number of medications reflected physical illness in these people, which vastly increased their risk of dying with either with or without dementia, compared to people who were older, age 80 plus, who might have been dying of natural causes or other problems anyway, whereas the younger groups who had a greater burden of illness were at higher risk of dying. So as I said, the increased drug count was associated with all-cause mortality, with a weaker association when dementia was included, and a stronger association in younger groups. Polypharmacy is an interesting question overall as to whether it's simply a marker of overall health or whether that itself is what's important in relationship with dementia or with death. Our data rely on death certificate diagnoses, and that's a limitation. And we were also unable to adjust for multimorbidity or specific diagnoses. We also had limitations on the covariates collected, and these data only include people aged 50 years and over taking one or more drug. In future, we're hoping to develop a national dementia dataset in Scotland, and using this dataset, we could also include people taking no drugs at all to increase the dataset and allow more sensitivity. We also plan to examine different combinations of drugs. I'd like to acknowledge my PhD supervisors and my funders, and here are my contact details if you'd like to get in touch. Thank you for listening to my talk. I'll now introduce the next speaker, Dr. Sylvain Licker. Dr. Licker trained as an MD and epidemiologist and now works as a postdoc at the Department of Epidemiology at the Erasmus Medical Centre in Rotterdam, the Netherlands. Through his research and educational activities, he studies and designs personalised strategies to optimise the joint prevention of co-occurring conditions in patients by targeting shared biological concepts and modifiable risk factors. In 2021, he was awarded his PhD entitled Maintaining Cognitive Health into Old Age, Population-Wide and Personalised Preventive Strategies with a cum laude degree. Dr. Licker is going to talk to us about maintaining cognitive health into older age and the role of individualised preventive strategies. Over to you, Dr. Licker.
Hello everyone, my name is Sylvain Licker. I'm a medical doctor and postdoc from the Department of Epidemiology, Erasmus Medical Center in Rotterdam, the Netherlands. And today I would like to talk about a very important topic, the role of individualized preventive strategies to maintain our cognitive health into old age. Before we dive into the matter, I would like to disclose that I have nothing to disclose, and now I'll start my presentation. So actually I would like to start with the take-home messages that I would like to convey for today. And those are threefold. Based on the study that I'd like to present today, we conclude that approximately 70% of community dwelling persons already qualify for cardiovascular preventive intervention, so regardless of their risk for dementia. Second, we see that the risk of dementia is at least as high among people that are eligible for dementia prevention trials compared to those that are not. And I would like to clarify today as a final message why we believe that we now need a lifetime risk perspective for dementia prevention, and that these findings call for adapted recruitment strategies for future prevention trials for dementia. Now, what do we mean with individualized dementia prevention, which is important to know before we can really discuss the study that we have done. So what we have seen over the past years is that modifiable risk factors for dementia account for like 30 to 40% of dementia incidence. This means that if you would eliminate those factors, like smoking, physical activity, but also loneliness, for instance, then approximately 30 to 40% of cases of dementia will be prevented. And what we also learn is that there's a lot of attention going on now in the field of dementia prevention trials. So these are largely based on trials that have been conducted for diabetes, for instance, another disease that's highly dependent on lifestyle. And what we, for instance, see is that the Finnish Diabetes Prevention Study Group, or the Doctors Extra study, is one of the key studies been to really initiate new dementia prevention trials. So it started in the field of diabetes, and now those concepts of those multimodal dementia prevention trials are being conducted in the field of dementia. And this is true because if we look back in the literature, for instance, we see that there are increasing numbers of new trials initiated, and those can be seen, for instance, in clinicaltrials.gov, a website that registers all ongoing trials worldwide. Now, what's the rationale of dementia prevention trials is that these largely base their trial group, their eligible trial group, on people that are older because they are then at risk for dementia, but also those that have suboptimal cardiovascular risk factors. So for instance, they are smokers, people with high blood pressure or high cholesterol. And it is believed that based on those risk factors for cardiovascular disease, they probably also are at risk for dementia. But it could be that based on the risk factors that they already have, that their physicians, for instance, their general practitioner or even their neurologist or cardiologist, is already inclined to start preventive intervention based on this high cardiovascular risk, based on those risk factors. So this actually brings up to a question whether it is useful to use those individuals for dementia prevention trials, because if they already started their preventive intervention, then what do we then do additionally in those trials or even in clinical practice later on? And this is then a scheme of one of the trials that we have investigated. This is the FINGER trial, which has become famous because it was one of the first trials to show efficacy of such multimodal lifestyle interventions on cognitive decline. And what you can see here is that I would like you to focus on this in this box here, is that there's a very intensive way of intervening on people's life in such trials. So you get nutritional counseling, but also physical activity and cognitive training even. And of course, there's a large part on the management of metabolic and vascular risk factors. And now it comes to my research question, and this is actually, is it useful to include people that are now in the trials, or should we rather look more for the people that are now considered ineligible for these trials? Because probably those people that are now considered ineligible also have a risk of dementia, and it could be that that risk is even higher than those that are not included. And that's not something you can study in a trial, because the people that you do not include, you cannot study anymore, because they are, for various reasons, but also for ethical reasons, not possible to then follow them up, for instance, for dementia. In a population study or in a cohort study that is observational, that is possible, because you can then mimic the trial eligibility criteria and also see what happened to those people that were considered non-eligible, and then follow them up for dementia. So this is exactly what we have done. So we first started with a literature search, including gray literature, but also the clinical trials, and try to identify large dementia prevention trials over the past years. So we set a criterion around 500 people, and the outcome should be something like cognition or cognitive decline or even dementia. What we then try to do is try to mimic the trial eligibility criteria. So we try to follow as closely as possible the in and exclusion criteria of each and every trial. And for that purpose, we use the population-based Rotterdam study, a large cohort in the Netherlands that includes more than 50,000 individuals that have been followed up for more than 20 to 30 years. And lastly, we try to calculate the preventive treatment thresholds for cardiovascular disease. And this is important because then we can see what happens to those people that are in the trials and what happens to those that are considered ineligible for the trials. And I will now try to explain more in detail how we did this. So for the literature search, we found approximately like 1,500 abstracts, and only 5 met our inclusion criteria, because most of the results that we found were, for instance, smaller trials, or they did not have cognitive decline as in primary or secondary outcome. And we also identified 5 currently ongoing trials. So these trials have not been published yet, but they were available in clinical trial registries. So in total, we have 10 trials that we studied. And now the Rotterdam study. So this study is already like more than 30 years old, because it started in 1989 with a first study wave. And later on, the study got expanded. And now for this purpose, in the current study, we try to focus on these 2 cohorts. And we did that for 2 reasons. First, because it's close to the original trial start points in the literature. And second, in these waves, a lot of data was available. And we needed a lot of data because the different trials used all kinds of different in- and exclusion criteria for their research. And we try to mimic that as close as possible. Important to say is that this is a cohort that has been started in like 2006 and has been followed up for up until now, 2020. So the dementia follow-up is already pretty long, which is an important point to mention here, because then we can reliably calculate what is then the risk of people that are eligible or are not eligible in the trial. So this is to show you what all kinds of data you need to really get to the point where you want to mimic eligibility criteria of dementia prevention trials, because one trial probably selects on genetic factors or cardiovascular risk factors, and the other uses more like gait variables or biomarkers or medication. So you need a whole host of different phenotyping to get those trials head-to-head alongside each other. And we are fortunate enough that in the Rotterdam study, we found 2 waves that had most of these data all available at a single time point. And there was also a miscellaneous group with, for instance, difficulties in communication, informed consent, of course, and conditions preventing cooperation as judged by the study physician. Now, cardiovascular guidelines are something that is long available in the literature, and these change over time, of course. We try to select ones that are considered most prevailing, and from the European, but also from the American societies. And we tested both in our analyses. And these guidelines, I think most of you are familiar with those, give some advice on what kind of risk percentage, predicted risk, you then have to start a treatment or lifestyle advice. And if your risk is getting higher, then of course, there comes also into play the drug treatments like blood pressure lowering medication or lipid lowering medication. You have these feasible or easy to use score charts where you can then use the clinical variables of a patient to indicate their risk, the predicted risk of cardiovascular disease. And based on that risk, you then can say, okay, what should I then do with the treatment? Start only lifestyle advice or also start the preventive drug treatment. Now, if we look back to the trials that we found 5 published trials. This is the part that I will mostly focus on because the results that we found for the ongoing trials were closely in line with those that we have now found in the literature based on the past trials. These are an overview of ongoing trials alongside those that were published. And as you can see here on this map, that there is a variety of trials also in geographical location. And it's largely now still missing in parts of Africa and Russia, but you see that they are increasingly starting new dementia prevention trials across the globe, where initially it started more or less in Western Europe and in Northern America. And some of these trials have been united in the Worldwide Fingers Network, which is a conglomerate, let's say, from the original finger trial that was published in 2015. So if we look into the eligibility criteria of the Rotterdam study, so this is in our observational cohort and not from the original trials, then we see that the eligibility ranged, and it ranged from like 48% to over or close to 90%. But it was largely in line with what we found in original trials. So we looked back in their reports and we found that the absolute difference between those trials was pretty small, which gave us some confidence that what we are doing here is probably reliable for the rest of our results. And of course, it was somewhat lower for the more memory clinic based trial. So the MAPT trial, for instance, recruited people from memory clinics and not only from the community directly. So if we look into the results, and this is one of the primary results that I would like to discuss with you, is that on the y-axis you see the eligible study population. So this is the percentage of people that is considered preventive treatment. And here you see on the right the ineligible study population. And on the x-axis you see the different trials. So what you now here can see is that, for instance, for the DRX extra trial, you see that like 60% of eligible people for that trial is already in red recommended preventive treatment for cardiovascular disease. And this is already 60% that is recommended. But if you also consider then the treatment considered category, then you already go to like close to 90 or over 90%. And this is something we see for almost every trial. So this means that most people that are eligible for dementia prevention trials, and the mean is just above 70%, is already recommended pharmaceutical preventive treatment for cardiovascular disease. So it is the question then, what do we then add with the dementia prevention trials? If you look into ineligible people, then we see largely a similar picture with slightly lower mean of people that is considered preventive treatment with some varying estimates. And you can also see that if the eligible people have a lower number, then that's something you would expect. Then the people that are ineligible are probably indicated the higher treatment threshold. If we now set out the risk of 10-year dementia incidence with the predicted risk of cardiovascular disease, then you see a positive correlation. In all the single dots are the trials that we found. So you can see that with increasing cardiovascular predicted risk, you also see that the dementia incidence is going up. And this could be reassuring for the framework that we're now using for dementia prevention trials. But on the other hand, if you know that your predicted risk is high, then probably those people already are recommended preventive treatment, which then makes it kind of obsolete that for dementia incidence countering, you need additional measures. What's interesting though is that if you then go back to a more lifetime perspective, so if you then calculate what's my lifetime risk of developing dementia, and you set this out to the predicted risk of cardiovascular disease, then you see an inverse relationship. The predicted 10-year risk of cardiovascular disease, the lower the lifetime risk for dementia will be. And this is partly has to do what we believe that those people that are at a very high cardiovascular risk are also those that are inclined to die of such disease because they are already at so many risk factors. And that's closely also related to mortality, which brings them at lower chance or lower risk to develop dementia later on, simply because they do not reach that age of getting at risk for dementia in the community. So what's then the message? And I already started with these 3 bullet points. What we see, approximately 70% of persons already qualify for cardiovascular preventive treatment, regardless of their risk of dementia. And we see that dementia risk is at least as high among eligible compared to ineligible people. So probably we need to focus more on not the people that are at highest cardiovascular risk to include for dementia prevention trials, but probably people that are more at the suboptimal range or below par cardiovascular risk threshold. So those that probably have only one single risk factor that we can treat, but those will be at a very later stage in life at high risk for dementia. So this warrants a more lifetime perspective on the prevention of dementia, rather than that we focus on a 5-year or 10-year treatment horizon that is now currently done. And I would like to thank you for the opportunity to present this work at this beautiful conference. But I would like to also acknowledge people from the Rotterdam study that have been participating over all those years, and the co-authors that have contributed to the study from my department and from our research group. And with that, I would like to thank you for the attention. And if there are any questions, I'm happy to answer them. Thank you so much.
Thank you, Dr. Lykke. We'll now move on to our next speaker, Dr. Katrina Davis. Dr. Davis trained as a doctor in the mental health of older adults and has an interest at that time in the links between hearing health and dementia. She worked as a reviewer on the National Institute for Health and Care Excellence, NICE, before transferring to King's College London. She now coordinates the UK Biobank Mental Health Outcomes Consortium and is an MQ Data Science group member. Her PhD, entitled Co-Prescribing in Dementia, uses the Maudsley Clinical Records Interactive Search Resource and is supported by a studentship from the National Institute for Health Research Biomedical Research Centre at King's College London and the South London and Maudsley. Her talk is on the evidence for prescribing statins and aspirin for people with dementia. Over to you, Dr. Davis.
Hello, my name is Katrina Davis. I'm really pleased to be speaking to you and following those two talks. My talk is on a specific dilemma about prescribing statins and aspirin and looking at evidence and how we produce evidence. So I'm going to start with why this is a dilemma, look at any existing evidence, and then about how we might generate more evidence using observational trials, and then some closing thoughts. So first, why might someone with dementia be on aspirin and statins? Well, lots of older people are on aspirin and statin. The most hard indication is for secondary prevention of major cardiovascular events. And I'm speaking particularly about myocardial infarction and ischemic stroke in this talk. Commonly, people with vascular dementia will be in this category. A softer indication for aspirin and statins is the primary prevention of major cardiovascular events. And many people with dementia will score as high risk and therefore be put on statins especially. Also, there's some theological ways that dementia pathology could be affected by aspirins and statins. So people might be started for that. But why not to give it? Well, those indications about primary and secondary prevention, they're from single condition guidelines, and they're not suitable for people with multiple long-term conditions. Specifically, the evidence cited excludes people with dementia who have different issues, such as a limited lifespan, medications having more side effects, and polypharmacy through a lifetime of accruing long-term conditions and risk states. So what are clinicians to do? There are no specific guidelines about people with dementia, and there are few about people with multimorbidity because of a lack of evidence. But if we're saying there's a lack of evidence, how are doctors supposed to support patient and carers to come to a decision? So in my PhD, I carried out 2 systematic reviews with a pharmacist colleague. We looked for side effects of aspirin and statins, as well as positive effects of long-term prescription of aspirin or statin. We found 5 papers on statins and 4 on aspirin that were quite mixed. So some were RCTs, randomized controlled trials, and some were observational trials. We also carried out a review of relevant guidelines, which is shown in the following summary slides. And the summary slides also split people with dementia into 2 main groups. Firstly, those with Alzheimer's dementia who have no history of cardiovascular events versus those with vascular dementia and a history of cardiovascular events. And we're going to use a traffic light system to look at both positive and negative effects. So for instance, looking at the existing evidence for statins on people with Alzheimer's type dementia. So there are some studies on whether statins affect cognitive decline in dementia, but they conflict. So ones where people were on statins before dementia took hold showed some slow progression, but an RCT didn't show any effect. And none of those really help us with our prescribing or deprescribing dilemma. For preventing cardiovascular events, there's no specific evidence, but as I say, primary prevention has a very low absolute risk reduction for statins. For adverse events, around 10 years ago, there were some studies from the USA that said that statins had a negative effect on cognition, and this could be quite harmful for people with dementia. But further evidence has shown that that effect is not the case. And so I think we can say that there are no direct negative cognitive effects. And actually, there are very few adverse effects for people with dementia taking statins. So if we move to people who have vascular dementia and previous cardiovascular events, there's actually no evidence about whether statins alter the progression of vascular dementia. And partly that's because giving statins has a big absolute risk reduction for people who are at high risk of cardiovascular events. And so it could be seen as somehow unfair if they were not given statins. And again, we don't have any direct evidence about safety of statins in vascular dementia. But if we extrapolate from Alzheimer's dementia, then it doesn't seem to be particularly bad. Moving on to aspirin. For people with Alzheimer's dementia, this also shows some conflicting evidence, showing that if you are on aspirin before dementia, there may be some slower progression, but if you start it when you first have dementia, it doesn't have an effect. For cardiovascular events, we know there's quite a big risk reduction in people who, we know there's quite a small absolute risk reduction in people who haven't had a previous cardiovascular event. So that comes out as about 1 per 1,000 people given aspirin per year prevented of having a cardiovascular event. And this needs to be weighed against the adverse effects of aspirin, which are quite considerable, and include severe bleeding. And the authors of the RCT speculate that there are people with dementia are more at risk of intracranial hemorrhage on aspirin than people without dementia. But looking at aspirin in people who have vascular dementia and previous cardiovascular events is slightly different, because these people are at high risk of further cardiovascular events. And it's been shown that giving them aspirin gives 20 fewer deaths from myocardial infarction per 1,000 per year. So then this has to be balanced against the adverse effects that we know about. Summarising, the existing evidence can answer some really specific questions about cognitive effects of statins or about bleeding in aspirin, but about the overall balance of positive versus negative, it's not that great. So we need more evidence. And this evidence is very unlikely to come about through RCTs, far more likely through a number of thoughtful observational trials. Observational trials are sometimes called pharmacoepidemiology, sometimes database studies, sometimes pseudo trials, comparative trials, sometimes termed as prospective, but I would say always retrospective. And this is me, the blue man with the magnifying glass, looking back from the present day to people prescribed statins many years ago. An observational study sounds really easy. You assemble the data, you split the cohort by exposure, you know the outcomes, and you interpret with an eye to confounders. But what does that mean? What is an eye to confounders? Well, to look at confounding, I'm going to look at the hypothesized effect of drug A on having a heart attack and myocardial infarction. To do this, I look at the influences on having a myocardial infarction. These include vascular risk factors. And then I look at the influences of being prescribed drug A, and those include vascular risk factors. So putting them together, the likelihood of both myocardial infarction and taking drug A is going to be influenced by the presence and severity of vascular risk factors. This is confounded by indication. It's a difficulty in estimating the effect of drug A because the disorder that it is indicated for also affects the outcome. Drawing these causal diagrams can be quite useful in kind of clarifying what you're looking for, what data you're going to need. This is my diagram from my PhD looking at statins and the effect on MI and ischemic stroke. So what do we do about confounded by indication? Well, we need a causal inference tool, so some way of telling whether the effect that we see is causal. And to do that, we need to control for the indication. So what we do is we one of the ways that we can do this is finding a propensity score. And that's the likelihood in our data that someone would be given drug A, given some chosen characteristics. And we can either choose those characteristics by asking people about how they prescribe drug A, or we can use machine learning to produce a highly dimensional propensity score that can take into account lots of other factors. There are other cause and inference tools. Ones that we talked about in a paper that we published with MQ Data Science Group were instrumental variables and inter-individual designs, but these aren't so suitable for this study. So back to my study. I sit as a researcher in the Clinical Records Interactive Search at Maudsley, so that's CRIS, which provides specialist mental health and dementia services. So far, the records are good for things like tracking cognitive decline and features of dementia, but clinicians don't necessarily record physical health systematically. So we need to be able to expand our search either into the full text of the notes or to link to other data sources. So for full text, we're going to need something like natural language processing, which turns full text concepts into some structured data. This is quite time consuming, and though CRIS has integrated NLP from its outset, it's still not possible to get a list of comorbid disorders. But we could easily get a list of comorbid disorders from the primary care records. You see, in England and Wales, people may have a handful of medical records, none of which routinely link to each other, which is bad for clinical care and worse for research. Luckily, some people have beaten a track to link these things, and so CRIS also provides a data linkage service, which enables me to link to GP and hospital records and death records. This is done in a way that has been approved by a number of committees with safeguards to ensure responsible research. It has to be remembered that while this data is owned by the data owners, it actually belongs to the patients. It's retelling their lives, and social consent is so important in these types of research. So one of the things that linking to primary care data can get me is longitudinal prescribing. So this is very, very early data. It's showing that in people with dementia, 55% of them were prescribed statins and 30% were prescribed aspirin. And they're fairly steady over time. If you look hard, you can maybe see that aspirin is declining slightly over time, but prescription of other drugs that provide antiplatelet effects are going up over that same period. So that's the end of my presentation. My closing thoughts are that prescribing and deprescribing statins and aspirin in people with dementia is a common clinical dilemma. That means that someone's been here before. The stone structure on the right is an inukshuk. You see it on trails where people want to show that they've got that far. People with dementia and their carers and their doctors are leaving these stones charting their trails. It's only responsible that we use them, but in a way that respects their privacy and the statistical rigor. So thank you very much. And I need to make my own thank yous, especially to my supervisor, Rob Stewart, to the pharmacist who helped, which is Delia, and all the CRIS and linkage support. On the right, you can find some further information on some of the things that I've been talking about. And my email is there, and I'm very pleased to take comments and questions now or to receive them later. Thank you very much.
Thank you, Dr. Davis. We'll now move on to the question and answer session, where all speakers are available to answer questions from the audience. Great. So thank you very much for everyone for your attention for those 3 talks. We're really looking forward to the Q&As now. So we've got one question in already, and we're very happy to take some in the chat. So if you have any questions, please send them in and we'll be discussing those live. So the first question that we've had through is from Jessica Camacho Ruiz. Sorry if I said your name wrong. And her question is there an essential factor to work on the prevention of dementia, or is it the set of preventive actions that reduces the risk? So we're looking at one individual factor that's more important than the rest, or is it more important to think about a whole set of actions? I was hoping Sylvain might be able to answer that question first, please.
Yes, thank you, Lucy, and also thank you for all the people that are watching and have been watching the presentation. I think this is an excellent question and a very timely one because we have seen in the literature that the Lancet Commission recently showing us that there's a whole host of risk factors that are shown to be important in the prevention of dementia. And I think this question really taps into that if we look up the individual risk factors and would solely work on them, then I think the preventive yield is limited. It's rather the whole set of risk factors that is identified in these reports that gives us the potential to really postpone or even prevent its onset completely. But also as shown during the talks and during my talk, maybe specifically, is that we're already doing in many countries a lot of preventive action for other diseases, and I think it's really the potential that we have to strengthen those actions to also solve the puzzle of dementia prevention. But I would say it's rather the set of risk factors that we should tackle rather than that we focus on one single target.
Thank you, and thank you for the question. Katrina, did you have anything to add about that topic of holistic prevention of dementia?
I suppose I would come in from one of the old hats that I used to wear, which was about hearing impairment and dementia. And so from that point of view, that's the kind of thing that could be tackled probably best by kind of public health intervention. So if, as well as testing people's blood pressure and cholesterol, when they had health checks, we also checked their hearing and told them about services they could use. Another thing, but it is everything in the round, and it's making sure that when we're doing health checks, we're not just doing health checks on the middle class, more well-to-do people, but we are actually being really inclusive and trying to get those people who don't usually attend these kind of things.
Absolutely, I'd wholeheartedly agree with that. I think we're at risk with things like brain health strategies of targeting people who are already doing all the things they need to do to prevent dementia themselves and living really healthy lives, and making those people even healthier. And sometimes we're at risk in high-income countries of missing out the people who are already disadvantaged. Thank you both for answering those. We've got another question come through from Marcela Marti Revello, and the question is, I think this one's for you, Katrina. So the prescription of statins and aspirins should be based on each case. So I take that to be, should it be a case-by-case basis? And could you say a bit more about that, please?
Absolutely. I think it should be a case-by-case basis, but trying to do research on a case-by-case basis is something that comes much further down the line. I think in order to kind of inform the case by case, we need at least some idea of what the actual risks and benefits are. And that's kind of where my research is at the moment. But I think moving on, incorporating these things into kind of electronic prescribing systems so that primary care clinicians and geriatricians can get alerts on what is evidence-based in a certain situation and is then able to discuss that with patients and their carers. I think that's where the real kind of thing happens, that person-centered care that actually puts people at the heart of their own treatment, and lets them make the call the shots. But we can't do that if we don't have the evidence.
That's right. Thank you. Sylvain, did you have anything else to add about that, about individualizing preventions that's already out there, like statins and aspirin? I think that was sort of the main bulk of your talk. Was there anything else you wanted to add to that question?
Yeah, that's true. But I also realize that I'm providing the talk from an epidemiological perspective, and I'm not in the clinic at a daily basis. So I fully agree with this because I'm trained as an MD. But from a research perspective, I would say give everyone at risk a statin and aspirin. but I do realize that this is not how we should practice in real life. But on the other hand, if you strictly follow the rules and then calculate all the predicted risks and the treatment thresholds as we have done in our study, then you'll see that most people that are at risk for dementia do qualify for those preventive treatments by and large. So it's something to think about, and perhaps it's not for now, but maybe in the future, in coming years, that we will see new trials coming up, trying to target those drugs and see how the preventive yield will turn out. But I'm also thinking about perhaps poly pills, especially in countries where we do not have the resources readily available. That it could be helpful to give people one pill with preventive drugs, and try to see it at first for of course for cardiovascular disease, but maybe later on also for cognitive outcomes or even stroke, to see how those pills behave, which could also help, for instance, to increase adherence. But this is something on top of my mind, and I would happy to hear others about this. But I also realize this is something for the long run and not for coming years.
Great. Well, as with all research, I think everything I've found in my research career is you don't get answers, do you? When you do research, it's just more questions. You just keep finding more questions, and it's great to have more things to look at in the future. We haven't got any more questions coming from the audience, but we have got time if anybody would like to add one in. In the remaining 2 minutes, I thought I'd just ask Katrina and Sylvain, before we put this symposium together, we'd all been sharing what was in our talks, and Katrina was talking about the real life trajectories of prescribing practices of, was it aspirins and statin? And aspirin, Katrina, and we were wondering about how that compared to sort of clinical practice, because you're using sort of real life data, but is that what people are seeing elsewhere as well?
Yeah, I mean, something weird happened when I showed my pharmacist colleague those graphs, and I was going, look, no one's doing deprescribing, and she was like, I wouldn't want them to deprescribe these things. If they deprescribe them, it's saying that they've given up, that they're no longer kind of interested in keeping people alive. So that was interesting, because I thought that she would be on the deprescribing side, but it just shows, it comes back to you being person-centered, doesn't it? You know, so we need to be able to offer people the opportunity to choose. But Dr. Sylvain's idea about a poly pill, I also like.
Yeah, it's interesting that about I suppose our ideas of deprescribing and what we should be doing, and all, you know, and older people medicines are bad, but as you say, for older people and for some of our other colleagues, actually we might give the wrong message by saying we should reduce people's preventive medication. Sylvain, do you think that in the Netherlands there's been a change in preventive medicine prescribing? Do you think that people are embracing deprescribing and sort of realistic medicine approaches?
It's a tough question, because it's a hot topic in the field of research, and you get a lot of funding for it, to be honest. But what we see in daily practice is that especially the GPs, they are overburdened. So a lot of specialized care is turned back to them. And what you also see is that then if for instance, cardiologists think that we should deprescribe some preventive pills, that the GPs are a little bit reluctant to do so because they already have so much on their plate. And then they also have to convince their patients that it's safe to stop. And that's something I think we do not always realize, that patients are also sometimes a little bit, they feel safe while taking the drugs. And of course, this differs a lot between affluent and more the non-affluent people, I would say. But especially those that have been really, really taking their pills for years and then to stop it, it's a really decision that you're not making at once. And that conversation takes time, and that is, in the Netherlands at least, the job of the GP to do. So it is discussed also in the politics, but we're not there yet. It's not.
Great. Well, again, lots of things to look forward to in the future. I think we're out of time for this session, so I'd like to thank you both again, Katrina and Sylvain, for presenting these talks, and thank you very much to everybody who submitted questions and who's listened to this symposium. And we wish you a happy rest of conference. I wish we were all there in Argentina. Thank you very much for listening.